Okay, so I've been asked to talk about the bony tumors of the cervical spine. The objectives, looking at the epidemiology of cervical neoplasms, an approach to the diagnosis of cervical neoplasms, and then treatment options. So when we look, the most cervical spine tumors are metastatic. About 10% are primary tumors. There are the malignant tumors, primary bone, and the hematopoietic. There's the benign aggressive and the benign. Approximately 15% of all spinal tumors are in the cervical spine, the majority in the dorsal spine with lumbar intervening. So the predominant presentation in most patients with spinal tumors is pain. And there are two patterns of pain. There's a pain due to the tumor itself. This is typified by night pain. Patients wake up in the middle of the night with pain, and that's probably due to irritation of the nerves in the periosteum. And then there's mechanical and radicular pain, so pain with motion and pain of nerve compression and irritation of the nerves. Neurologic deterioration is often one of the presenting symptoms. Typically in the cervical spine, this is myelopathic, though occasionally radiculopathy. And of course, there are some that present incidentally during the workup for other tumors. Looking now, going through the primary malignant tumors, chordoma is by far the commonest, osteosarcoma much less common, and then the hematopoietics, lymphoma and myeloma, actually, I've sort of classed those separately. The hematopoietics are probably more common than the chordomas, but they're not truly a primary bone tumor. So chordoma is about 5% of all malignant tumors of the spine. The majority of them are sacrococcygeal. About 40% occur in the upper cervical spine. And the reason for that is, remember where this is a primary notochordal remnant, and the notochord starts folding over in the middle of the spine, progresses towards the ends, and that's the reason why we see this more commonly at either the cervicothoracic junction or the lumbosacral junction. Male to female prevalence is 2 to 1. Mean age of presentation is 50 years. But remember, since these are primary notochordal remnants, these are present since birth. About 5 to 10% of these will metastasize. Again, the most common presenting complaint is pain. In the patients with lumbosacral chordomas, sphincter disturbance, obviously not such an issue in the occipitocervicals, and radiculopathy. They will occasionally involve adjacent vertebral bodies, but they tend to spare the disc space. And this is just an example of a chordoma showing the typical increased signal intensity on T2, spinal cord compression, thinning of the cord, and this degree of thinning of the cord tells you that this tumor's probably been here a while. Here in the axial view, you can see tumor here, fairly typical appearance. The management of chordomas, ideally, because this is a locally aggressive, tends to be locally recurrent malignant tumor, you want to try and get a complete resection. Obviously, at the occipitocervical junction, a true en-bloc resection is difficult. The key in the cervical spine, as opposed to the lumbosacral spine for chordomas, is where is the vertebral artery and what's the status? Do they have collateral flow through the other side? Can you sacrifice the vertebral artery? Historically, post-op X-ray, wide field XRT has been recommended for these. Now the data is that stereotactic radiosurgery, or proton beam, if you have access to those, is preferable to wide field for residual control. There is no effective chemotherapy for chordomas. Moving on now to osteosarcoma. It's rare. I mean, osteosarcomas are rare. Only 2.2% of osteosarcomas are in the spine, and most of those are thoracolumbar spine. So it's exceedingly rare to see an osteosarcoma. Again, present in the second decade of life, slight male preponderance. The main thing here is diagnosis, getting them diagnosed, and they tend to treat them. Oh, sorry, they may occur as a result of Paget's or XRT. The management, neoadjuvant chemo, get them on chemotherapy beforehand to shrink the tumor. Tumor shrinkage is also predictive of outcome. The more tumor shrinkage you get, the more likely you are to cure them. An aggressive resection, and again, postoperative X-ray therapy in general, these people don't do well. And the main reason for that is it's impossible to do a true en-bloc resection in the spine. Moving on now, the benign aggressive tumors. There are 3 of these that typically occur in the spine, almost always at the cervical-thoracic junction, C7 or T1. And these are the giant cell tumor, the aneurysal bone cyst, and the eosinophil granuloma. And this is a fairly typical example of an aneurysmal bone cyst. And the treatment of all 3 of these pathologies is the same. It's intralesional excision and bone grafting. If it involves both pedicles, you probably need to also do an instrumented fusion on them. So now getting to the common stuff, the stuff you're really going to be dealing with is metastatic cervical disease. So the key to metastatic disease is really working the patient up, establishing the diagnosis and the prognosis. So first, if you see a tumor, is this a known pathology? You know, if this is a patient who has known metastatic breast or lung or carcinoma, then you need to look at what is the extent of the local disease in the spine, the extent of the systemic disease, their neurologic status, bony stability, and finally their life expectancy. These are the sorts of things you're going to look at when you're looking at metastatic cervical disease. So the first is, what is the primary? That's important both for prognosis and for treatment options. The more radiosensitive a tumor, the more likely you are to treat it that way. And then there's also the extent of the disease. Do they have liver mets? Do they have lung mets? Brain mets? All of this comes into it. So when we look, then the next is, where is the tumor in the spine? Is the tumor in the anterior vertebra? The main difference between the cervical spine and the thoracolumbar spine is essentially the cervical spine, instead of having an anterior and a posterior, really has 4. There's the anterior, there's the 2 lateral pillars, and the posterior. And so you now have to think a little bit differently in terms of the bony involvement. So you can have anterior, posterior, and then you have to sometimes look at the lateral, and you'll treat the laterals a little bit different. And of course, many of them will involve multiple columns. So this is just a couple of examples. This is a CT scan showing a fairly typical lytic metastasis involving predominantly the anterior column. Is more a lateral, and you can see that the contralateral side is still intact. So in some of these patients, you can do a little bit of a less aggressive treatment, particularly in terms of resection, stabilization, maybe only approach, and these are ones that might be approached more from a lateral approach. And again, in one like this, you really need to look at what the status of the vertebral artery is in planning your treatment. And here's an example of a predominantly posterior lesion. Although it does track around a little bit in, you can see here essentially the C2 lamina is completely infiltrated with tumor, but an intact C2 vertebral, or intact C2 vertebral body. So once you've made the diagnosis, you need to look at your treatment options. In some of these patients, if they have widespread metastatic disease and you have an incidental finding of a lesion at C3, you can often just watch them. They'll be dead of disease before that C3 lesion becomes symptomatic. We have the option of radiation, typical wide field radiation, or now stereotactic radiosurgery. And then when we look at surgery, there is intralesional gross total resections, which is often what we're doing. I put en bloc in quotes. People do talk about en bloc resections. Very difficult to do in the cervical spine, again, because of the presence of the vertebral arteries. And you can't really do a true en bloc resection. And then finally, I'll talk a little bit about this concept of separation surgery. So again, in observation, it's reasonable in patients with an incidental discovery, particularly tumors with good systemic treatments. So for instance, an incidental lymphoma in the cervical spine, you treat the systemic disease, and then the epidural lymphoma will resolve. You may want to consider adjuvant radiation of these treatments if there isn't good systemic treatment. Wide field irradiation is, you can use irradiation as a standalone treatment in patients who are neurologically intact with a radiosensitive tumor. But if they've already had collapse and they have bony compromise, radiation is not going to get rid of bone or cartilage. It will get rid of epidural disease. but you can't really rely on it. Once you get bony compression, you're looking pretty much at surgery. This is just that patient I showed you a little bit before, because I wanted to show that patient before was a breast carcinoma, and she was postmenopausal with a breast carcinoma, and I felt actually that this was something that we could potentially treat with radiation alone, as she was neurologically intact. She had a capacious canal with no spinal cord compromise. Her main presenting complaint was neck pain, but it wasn't the mechanical neck pain, it was the tumorigenic neck pain. And this is a CT scan done 6 months later after radiation, and you can see that what's happening is that that essentially within this there were still bony spicules, and after we get local control with the radiation, you can see she's essentially reconstituting a lamina. So you can actually get, in the radiosensitive tumors, you can actually deal with surprisingly large tumors without surgery. Stereotactic radiosurgery is a newer paradigm, and we don't know where it's going to be yet, but as I look at things, it's becoming more and more useful. Essentially, stereotactic radiosurgery is conformal radiation. All tumors are actually radiosensitive. So we were taught, that renal cell is not radiosensitive. No, every tumor, if you blast it with enough radiation, the radiation will kill it off. The problem that we have in the spine is we have to do so in a way that we protect the spinal cord. So what stereotactic radiosurgery does, by using multiple beams coming from different directions, is we're able to focus the radiation on the tumor itself, and you can have a very rapid fall off of radiation dose over a matter of millimeters. So that this allows us to get very high doses of radiation, and so tumors like renal cell have now become treatable by radiation. So again, we look at using stereotactic radiosurgery as a treatment in the neurologically intact patient where we have separation between the cord and the tumor. You need a couple of millimeters of CSF on your investigation, on your MRI, to make it safe to proceed with stereotactic radiosurgery. And again, doesn't care how much radiation you got, radiation doesn't get rid of bone pressing on cord. Compression, you do need to do something. So surgery, this was the paper, I put this in so that everybody's got the reference. The Patchell paper from 2005 wasn't actually looking at cervical, but it still applies. It was a randomized controlled trial of radiation alone versus surgery and then radiation. It was originally powered to 200 patients. They stopped it halfway through because the differences were so huge. Patients who had surgery did better. So this is where now, when I was a resident, people argued over whether to do surgery or just radiation. This indicated that yes, for the majority of these patients, now all of these patients had, none of these patients had highly radiosensitive tumors. So there were no myelomas, no lymphomas. They were all neurologically compromised. So this study doesn't mean that every tumor needs surgery, but in neurologically compromised patients, patients who got surgery did better. So the principles of surgery for cervical tumors: you need to decompress from the direction of maximal compression if you can do that safely. No point in going anteriorly if the compression's behind the cord. You need to reconstruct the anterior column if it's deficient. Anterior reconstruction alone if one or two vertebral bodies are involved. But if you get beyond that, you're probably going to need to go anterior, posterior. If they've got mostly posterior disease, go posteriorly. You want to do long constructs. And when looking at doing your construct, what I look at is if they've got a life expectancy of greater than a year, I look at doing something biologic. I will bone graft them. I typically use allograft. If they've got a life expectancy of less than a year, what I will do is I will just instrument them, because their instrumentation will likely outlive them. En-bloc resection became a big thing in the early 2000s, particularly for isolated renal cell metastasis. There was one study that showed improved survival if you did an en-bloc resection. Again, difficult to do in the cervical spine, and the reality is with the advent of radiosurgery, this is probably no longer a consideration. So the last thing I want to talk to you about is this concept of separation surgery. So we know that if we've got space between the spinal cord, that stereotactic radiosurgery is very effective. So historically, we were doing gross total resections, intralesional gross total resections. If you've ever tried to do that in a renal cell, and the 5 and 10 liters of blood loss that you can get, that's not a very fulfilling surgery to do. But you had to do that because we had no way of getting local control of the disease in renal cell. Well, now the new paradigm that we have is to just decompression, that we create a space between the spinal cord and the tumor to allow radiosurgery. So here's just an example. This is a patient, 2 scans done. This was the original scan at the time the patient came in. You'll notice epidural disease with this cord being compressed here. Laminectomy's been done. The cord is now decompressed, and there's some CSF around the cord. But we didn't go in and remove vertebral body. We've left some of the pedicles behind. All we were trying to do is get that. And the reason for that, this is the same patient. This is a model of what you would need to do with radiosurgery to control that tumor. And essentially what you need to know is that green is good. So you see it's red and yellow all the way around the cord. So in this, before the decompression, there's no way you could have adequately treated this tumor. Here's the same modeling, the markup to decide where the radiation dose would go after the decompression. And you can see here, so a much lesser surgery in terms of time and effort and cost to the patient, and it still allows. So the advantages of separation surgery, it's a much shorter surgery, lower blood loss, and in my hands now, what I'm tending to do with a lot of these is combining this with percutaneous instrumentation, so that I do a very small incision, a very focal decompression, just to get a few millimeters around the cord, then percutaneous instrumentation. So in conclusion, primary malignant tumors are rare. It's mainly chordomas. They need to be treated with, quote, en bloc resection. You need a total resection. Benign aggressive tumors, usually treated by intralesional resection and bone grafting. Metastatic disease, establish the diagnosis, estimate longevity, and there are multiple treatment options. And we have time for maybe a question or two. Yes, Jakob.
I like this slide very much. Is this going to be on the handout?
Yes.
Because I will need this. This is very nice. You show very nice that if it's really tight, I think you have to decompress these patients.
Yes.
You know, we frequently have the discussion when those patients go for radiation, we are not involved, and then in the middle of the night they show up for the tetraplegic.
What I also didn't talk about, which I'll just quickly add in because it's kind of interesting. Again, because the stereotactic radiosurgery is a very highly focused dose, if you have to go back in and operate on them later, you don't have the same wound breakdown problems because the skin has not received a high dose. And second, there's now some data out of Lily Angelov, one of our partners who runs our spinal tumor program, and Ed Benzel have done a really nice study that actually showed that, again, because the postoperative radiation is very conformal, we're getting higher fusion rates because we're not irradiating our bone graft.